Hello and welcome to this session, which is entitled Advances in Renal Denervation from Patient Selection to Procedure. It's my distinct pleasure to welcome not only you, but also to welcome the faculty here. David Kandzari on the left-hand side from Atlanta in the US. Hi, David. Rasha Al-Lamee from London in United Kingdom. We have Flavio Ribichini from Italy and Andrew Sharp joining us. This symposium is happening on World Hypertension Day, and for sure it's an important day to create awareness for a devastating disease, which is hypertension. And you can see here a recent publication indicating that only 23% of all women and 18% of all men have their blood pressure controlled to target values. And we know that this translates into worse outcomes. It increases the likelihood of getting a stroke, a heart attack, chronic kidney disease, and atrial fibrillation. Absolutely no question relates to the fact that antihypertensive drugs lower blood pressure very efficaciously, very safely, and they are widely available, cheap, but most of the patients are not taking them. And this is an example, a kind of meta-analysis where so-called resistant hypertensive patients were included. And you can see that 1 out of 5 patients is not taking a single tablet that we are prescribing. And almost half of the patients is partially non-adherent, meaning these patients take a tablet, leave others out, and we, of course, do not know which drugs are on board. Denervation represents an alternative treatment, a device-based modality, and we have learned a great deal on the importance of renal sympathetic nerve, the central sympathetic nervous system, and its interaction with various organs in our body, including the kidney. And there's a bidirectional relationship between the kidney and the central nervous system, and we can lower renal sympathetic activity by ablating the nerves that are located in the periadventitial space. By doing so, we decrease central sympathetic nervous activity. And beside other mechanisms, we are lowering blood pressure in patients at high blood pressure, at high cardiovascular risk. Together with me is Rasha. Rasha will serve as the moderator, and I'm handing over to you.
Thank you very much, Felix. Well, it's a pleasure to be here today and to be finally face-to-face all together again. And I know we've got audience at home as well. What's really important throughout this session is to keep it interactive. So there are many, many ways that you can interact. There is the option to use the chat function on the online portal and ask questions. And we'll be keeping an eye on all of those questions and putting them to the discussants throughout the conversation today. Also, there's the option to stand up if you're brave at the mics, and we'd really encourage the live audience to do that, and we will be looking out for you and your questions. And then importantly, we have a few polling questions because we'd really like to try and lobby or work out what's going on out there in clinical practice, what are we all doing, and then maybe talk about how this might change in the future. So importantly for you who would like to interact with the poll, this is how you do it. So you go onto the online app, you can click on Interact, and if you click on Studio A, you should be able to see the polling questions. And we're going to start with a little practice. So how about everyone takes out their phones and goes onto the polling question now. And the first polling question is, are you currently performing renal denervation? Yes or no? So feel free to enter those questions now, and we're going to leave that there for a while and move on, I think, to our conversation, and then we'll come back to the answers of that for the discussion.
We can probably frame the learning objectives for this session too. So we want to understand what the real-world experience with radiofrequency renal denervation is and how we can integrate renal denervation in patient management. We want to understand how we can partner with referring physicians, those who take most of the time great care of patients with uncontrolled blood pressure, and how we can select patients for renal denervation in a multidisciplinary approach. And we want to understand the latest preclinical and clinical data on the long-term safety and efficacy of radiofrequency renal denervation. And I think this slide is also important.
So what's really key to remember today is it's World Hypertension Day today, and Medtronic are obviously kindly sponsoring this session, have really committed to trying to increase the amount of funding that's available for hypertension research across the world. And so if any of you go onto that QR code and feel free to like or share or comment on the post that you'll see there. And if you do that, Medtronic will in kind donate either $10, $15 or $20 towards hypertension research and the management of patients across the world with hypertension, trying to make sure that we really reach out to those underserved communities.
Thank you, Rasha. And you mentioned it already, it should be an interactive session. So please use the panel here for all your questions that you have. And without any further ado, I'd like to ask Andrew now to start this session with the first presentation. And he will talk about the evolution of radiofrequency renal denervation technology and the related evidence. Andrew.
Thanks very much, Felix. And thanks to the sponsors and for the organizers for the invite. So renal denervation's come a long way. We're going to talk about radiofrequency renal denervation here, which has undergone an evolution, both in its evidence, its technique, and the technology that delivers the procedure. So RF has been recently demonstrated in several sham-controlled trials to be an effective therapy for uncontrolled hypertension. And we've managed to publish several in The Lancet in the last 4 or 5 years, showing significant blood pressure reductions that now we've just shown are sustained out to 3 years. And that's in the presence or absence of drug therapy. So what RDN is doing is it's modulating the communication from the brain to the kidney and the kidney to the brain. So it's a two-way process. And that probably explains why some of the blood pressure lowering that we see doesn't occur immediately. It occurs as a result of modulation of the outflow from the brain sympathetic nervous system control. So what have we learned over the last 7 or 8 years that has helped us to reboot the field? Well, the first is that despite textbooks going back to ancient Egypt, our understanding of renal nerve anatomy has evolved. We now see that renal nerves do not necessarily wind around the artery from its origin to the kidney. So what can happen is they can come from quite a distant position off the aorta and travel towards the renal arteries, arriving in contact with the outside of the renal arteries quite distally along its length. And in this study, we showed that 63% of kidneys had renal nerves that joined the artery beyond the bifurcation. Now, those of you who were in renal denervation at the beginning, you may recall we were taught to just denervate the ostium, the proximal vessel, and the mid-vessel, and to stay away from the bifurcation in case there was any trouble there. In fact, what we've now learned is that in order to get effective denervation covering most of the renal sympathetic nerve architecture, we really do need to be engaging with that area around the bifurcation and in the proximal branches. We also, at the beginning, weren't sure what to do about accessory arteries. So about 1 in 3 of humans will have accessory renal arteries, more than one artery to a kidney or both kidneys. And we've now learned that there's significant innervation to those vessels. And so if we left them out, we may leave behind incomplete denervation and therefore an incomplete blood pressure response. Oops. So this is just a better understanding from pathology prosections of how we apply that information. So renal sympathetic nerves, para-aortic region, and they then give off postsynaptic nerves down and wrap around the bifurcation, which hopefully you can see here. You can see my cursor there. Do you see how the plexus forms around the first order branches of the bifurcation of the renal artery? We also see that there are other structures around that we do not wish to denervate. So the kidney being an important one. So whenever you're delivering this therapy, we stay outside of the parenchymal outline on X-ray, which is very easily seen within a procedure. And we also want to stay away from things like the ureter and from lymph nodes, and from ganglia, inferior vena cava, and so on. And all of these structures are very helpfully designed in order to have cooling facilities that mean that we do not deliver significant energy to these, and I'll hopefully be able to demonstrate that to you shortly. So there's now been over 20,000 procedures with radiofrequency using the original Flex and now the spiral device, and more than 7,000 patients published, so we've got a lot of experience. The current device is a nitinol electrode with 4 electrodes at north, south, east, and west. So you put a wire down the vessel, you slide your catheter over it, you pull the wire back, and it springs into this spiral shape that allows us to denervate in a stepped quadrant manner. So we're not doing it in one spot, and therefore risking a problem of stenosis. We're doing it in a step-back fashion with each quadrant at a different point longitudinally. And we've got quite a wide range with this device of 3 to 8 millimeters. So you can see here the image on the left looking down inside an artery, how the device takes shape and how it delivers its energy. And when we started off this field, we saw this thermochromic gel model that was published everywhere that made it look like there were these beautiful symmetrical energy depositions that were occurring around the device. And I think that's not how the real world works. So what the real world looks more like is on the right. So this is a porcine model. And this is a single energy delivery that has occurred around 10 o'clock within this artery. And what we see is that the energy will run through the periadventitial fat until it dissipates or it hits a structure that sucks that energy away. So if it hits a structure like the renal vein, because the renal vein is carrying blood, that blood will take that energy away and dispose of it. So it acts as what we call a heat sink. And so when energy reaches the renal vein, it will stop. Similarly, as it comes to less conductive tissues like lymph nodes, if it gets towards a lymph node, it will then dissipate and the energy will stop at that point. And every other piece of tissue in between the renal arterial wall and the edge of the view has different conductance properties. So what you get is a sort of mushroom cloud effect, where you get different depths and different densities of energy delivery, and therefore denervation properties to the tissues that lie within. And in this prosection, the red circles are the ones where our renal sympathetic nerves are. And so you can see how to say it denervates in these 4 hemiclovers like you're seeing in the gel model is not the real world. And this is just a cartoon version of it. And we've actually looked at this now to just see what it does. So if you look at RF ablations, the maximum lesion depth in a porcine model at 7 days is about 6.8 millimeters, and the average depth is between 4 and 4.5 millimeters. But the depth doesn't tell the whole story, because if it stops at the renal vein, there are very few renal sympathetic nerves behind the renal vein, so you get quite a short ablation depth there. Whereas on the other side, on the north side here, this is the collapsed renal vein you see at the bottom. On the north side, there are many more renal sympathetic nerves going out deeper, and the energy will conduct in that direction preferentially. So we're getting quite an appropriate lesion depth, but not excessive, that we're worried about other tissues. So what is it about renal sympathetic nerves that makes them well suited to radiofrequency energy? Well, if you look on the left, this is a myelinated peripheral motor axon. So this material round here that looks almost like plastic tubing, this is the myelin sheath that is designed to protect peripheral nerves and to structure them. You do not get that with sympathetic nerves, and so that lack of protective layer and that lack of skeleton is actually helpful to us when we want to ablate these nerves. Because A, we don't have to deliver as much energy to get to the axons inside of it, and B, if there's any attempt to regenerate, there's no skeleton within which to regenerate, unlike with myelinated nerves, which have a skeleton around the outside of the axons that provide a conduit to channel any attempt at regrowth to allow reconnection. That does not occur with sympathetic nerves. And this is just an example of it with electron microscopy. So what we found in a porcine model is that when you do an ablation lesion, you disconnect the proximal cell body to the distal nerve, and that loss of nourishment and conduction means that the distal nerve atrophies. Now, this isn't atrophy as we think of it in a muscle. What this means is that we have a loss of axonal tissue that's detectable within that downstream tissue, and that downstream nerve becomes useless. It's not something that can be resurrected. Even if somehow there was regrowth of nerve tissue to connect proximal to distal, which is unlikely because there's no structure, what we just get is chaotic proliferation of material from the surrounding structures. It's connecting a proximal cell body to effectively a dead distal nerve. And so we're pretty confident from our analysis of a porcine model that it's unlikely that there'll be regrowth. So once we adequately get the nerves, we think they will stay got. This is an example. So this is in a porcine model where we looked at renal cortical axon density, and what we've done is stained for tyrosine hydroxylase, which is an enzyme involved in the neurotransmitter production at the end of the renal sympathetic nerve. And what we saw is that there's plenty at the beginning, but after denervation, there's no evidence of tyrosine hydroxylase activity or presence in the downstream neurons. And therefore, we think that there's no axonal activity or ability to produce axonal activity there. And then when you look at the output of tyrosine hydroxylase, which is renal norepinephrine, which is the neurotransmitter for renal sympathetic nerves. We see that when you pulp a section of the renal cortex where it's active and you look at concentration, after a spiral procedure in a porcine model, we see a significant drop in renal norepinephrine concentration that is in keeping with an effective denervation. And we see this at day 7, and we see this in a parallel group of animals at day 180. So it looks like we are able with this technology, particularly when we focus on a distal energy delivery, to denervate the vessel effectively, to denervate it permanently, and then to reduce that sympathetic activity that goes in both directions and will hopefully then produce an immediate response by disconnecting nerve traffic from the brain to the kidney, but then also hopefully a secondary response as the brain remodulates total body sympathetic nervous system activity. So in conclusion, renal nerve anatomy, our understanding of it has evolved incredibly. Leonardo da Vinci was painting pictures of renal nerve anatomies, but it's actually the fixation of the nerves that has come on that has allowed us to understand better the path of those nerves. And that made us understand that the original technique risked variability. And now we've adapted that to move away from the proximal renal artery to focus more distally at the distal main and around the bifurcation. Spiral uses a shorter energy delivery with this nitinol device than we used to at the beginning. And it's got good safety data now and very controlled energy deliveries out to an average of 4 to 4.5 depth, but it will go out to 6 or 7 millimeters where there is a possibility for the energy to run through the periadventitial tissues, as I described. We have data that we'll hear more about, but the data support the fact, 3-year data from the global registry, that there's not re-innovation, and we see from the preclinical data that re-innovation is unlikely. So I'm now going to ask a polling question just to see if anybody was awake. If you're able to go onto your app and you open Studio A, you should see this question, I hope. And it should say, renal sympathetic nerves are typically closest to the lumen. So given that many of you may not have the app, I'll just do a show of hands if anyone's brave enough. It's dark, right? So we can't see you. Typically closest to the lumen. So where do the sympathetic nerves get closest to the lumen? Ostial, mid-main, and distal or branches? Distal. Okay. Everyone was listening. That's great. Thanks very much.
Thank you. Thank you, Andrew. That is indeed the ultimate target of renal denervation, right? The renal sympathetic nerves. And you mentioned it. We learned a great deal about the anatomy, the distribution, and the density of this target. Are there any questions from the audience or from the chat? There's one question. Please go to the microphone and identify yourself, please.
Well, thank you very much. I am Dr. Ibrahim Mufil-Habadi from Jordan, interventional cardiologist. I have 2 questions. The first question, we stopped this procedure a long time ago because of the complications, thrombosis, and so on and so on. So why we, again, coming back to this procedure, the first question. And the second question is, what is the percentage of reducing the blood pressure and how much it reduced by this technique? Okay, thank you very much.
So great question. Shall I take them?
Sure.
So the first one is why we stopped. So we stopped in 2014 after Simplicity HTN3 was negative. So why was Simplicity HTN3 negative? It wasn't stopped on safety grounds. In fact, the safety of the procedure...
That's an important comment, yeah.
Yeah, the safety of the procedure was exactly the same as the sham procedure. And the complication rates are incredibly low in all published data on this. There wasn't any evidence of thrombosis. There was evidence of microscopic thrombus on an OCT study that turns out to be clinically inconsequential. So we didn't stop because of safety. It's a very, very safe procedure. The reason we stopped is that HTN3 was negative, which was a randomized sham-controlled trial using the original Flex device. So the Flex device was like a finger, and you steered it like an early EP device, and you had to draw the circle yourself in a retrograde circle running back along the main body of the renal artery. And we were asked to stay away from the bifurcation and concentrate really on the mid and the proximal vessel. As I've just shown you from the anatomy, that turns out to be precisely the wrong information. In that trial, there was an average of about 11 denovations deployed across the 2 arterial beds, so roughly 5 each. What we showed is that in order to get a bilateral retrograde spiral, that's what you called a successful procedure. It turned out that that was only possible in about 6% of the patients treated with Denervation in that study. So 94% of the patients in the treatment arm did not get the designed and recommended technique. So what we had in HTN3 effectively was a sham procedure against a sham procedure. And we then had lots of tablet changes that dropped the blood pressure in both arms.
So methodological issues with the trial, right?
So we went back and redesigned everything. Catheter, energy delivery, energy modulation, how to do the trial, how to stabilize the medicines, and then how to effectively deliver it. And that led to 43 ablations bilaterally occurring in the next trial with the new catheter versus 11 in the original HTN3 study. So that's why we stopped, and that's why we've restarted.
Probably in terms of efficacy, David, you are showing some data later. I've seen. So can you comment on the question from the colleague here? What is the efficacy that one could expect with renal denervation as being done?
Sure. So to begin with, over short-term follow-up, the efficacy we see with regard to a blood pressure reduction is analogous to that relative to a single antihypertensive therapy, roughly 10 millimeters mercury reduction in office systolic blood pressure at early time periods of 3 to 6 months. However, as we've recently published and presented for 3-year follow-up in the context of medications and similar medication burden to the sham control group, through 3 years, we see reductions from baseline to about 20 millimeters mercury. So we see a continued divergence, an escalation or a divergence, an exaggeration of the benefit over even longer term follow-up. And to supporting on the clinical and the preclinical evidence, to Andrew's point, we don't see a regression or suggestion of reinnervation, which has been suggested by some.
Thank you very much, David. Flavio, maybe I could bring you in. We have a question from the audience that's really kind of pertaining to your talk, that you're about to talk to us about the real-world experience. And the question that we have from Lal Mughal from home is saying, what's the learning curve really for this technique? How many cases do people need to do to master it and be able to do it on their own and become an independent operator? And where do you see the focus being? Will this be a widespread procedure in lots of centres, or will it be in more specialist hands that people really acquire the knowledge?
Well, it's a very important question. It's not easy to answer because, of course, that depends on the experience of each operator. If you are an experienced operator on performing, for instance, renal artery stenting, then the procedure is very, very easy. If you have never catheterized a renal artery before, then you need some training. The advice would be to observe at least 4 or 5 procedures and then to work with an expert for another 4 or 5 procedures. These 4 or 5 is a number I've just invented in this moment. I mean, it's not written anywhere. But this will help you to understand, to start with a non-selective angiogram with the pigtail, because sometimes the arteries are not where you expect. And if you try to engage it selectively because you are good and it's easy, you will spend a lot of time and you will get a lot of contrast, and contrast is a poison for the kidneys. So non-selective pigtail, then you see where there are the arteries, you will see which kind of catheter will give you the best support. Then the technique for a cardiologist is simple. It's a wire, it's a coronary wire, it's pushing a catheter with a very good deliverability, and it takes time to irrigate the energy. It takes at least 1 minute for each ablation delivery. Then what to say? I mean, it's all based on the experience.
Where do you see it going in terms of centres? Do you think there's going to be a rollout to lots of centres, or will this be in specialist hands only?
I think that as the treatment is concerned, the therapy is very simple. Can be performed by any interventionalist after adequate treatment. I think what is necessary is to centralize the patient in a dedicated center that has all what is needed to get the patient referred, to rule out of the secondary causes of hypertension, to take care of eventual complications, which are really very, very infrequent. Most of them as just minor complications at the access site on the groin. Of course, to check for the renal function, because you give contrast, you get into the artery. Normally, all these arteries are normal, so there are not risk of embolization, of dissections and all that. So the important is to centralize the treatment in dedicated centers. But for the operators, I think that there is no need to have very, very high volume centers to do that.
Thank you very much. And now I think it's probably time to move on to our next talk. So, Flavio, if we could ask you to come to the lectern, and I think you're going to speak really to this point of navigating the procedure, the kind of real-world experience that you've had from your wealth of experience.
Yes, thank you. This talk is totally linked to the previous one. We are, almost all of us, we are interventionalists, and we have lived all the development of devices. And until a few years, we wouldn't implant a drug-eluting stent without knowing the animal results. And we had Renal Virmani showing us what was the endothelialization and the late reactions of the polymers and all that. Renal denervation needed this information, and what Andrew Sharp has shown is absolutely reassuring, because there is clear evidence in the animals, and these are more than 150 pigs, I guess, so it's a very large anatomic and histologic examination, that what we are going to see now in terms of clinical results is supported by clear evidence of animal efficacy and safety. So I will start with a proof of concept. So we want to know whether radiofrequency renal artery ablation thus produce lower pressure. So this has been tested in a model of study that has been developed after the hypertension 3, after the mistakes that Andrew alluded before, which is the proof of concept of efficacy. So are patients naive of drugs? So these are patients with hypertension, but not taking drugs. And these are the results. I mean, the results are published, you know them very well, but one of the most important differences in between this device-based therapy and the drugs is the effect on blood pressure lowering is totally independent of pharmacodynamics or pharmacokinetics. So what you see is a reduction of the blood pressure that lasted 24 hours a day. Independently, if you are eating, you are sleeping, you get angry, you are running, or whatever. And this is very important because we know that most of the clinical events related to hypertension happened early in the morning, while you are sleeping and waking up, and when the drugs have this problem of gap in the dosage and the pharmacokinetics. Second is the demonstration that the medications add effect on top of medical therapy. This is the second clinical research model, which is called ON-MED trial, and these are patients with worse hypertension, higher hypertension values that have been randomized to continue the drug therapy, plus a sham procedure. So these people went home convinced that they got the procedure, they got the puncture in the groin, they stayed in the hospital, compared to those who continued the medical therapy plus the renal denervation. And again, look at the difference. On the left side, you have the pressure blood drops, systolic and diastolic, in the patients without medicines. It's 5 to 9 millimeters of mercury compared the 24 hours on the office measurements. And on the right, you have the pressure drop after medical therapy in patients that were taking at least 3 drugs. So that you see that the effect is consistent regardless of the fact that you are taking or you are not taking the pills. But what is even more important, and it's strongly supported by the animal data that Andrew showed, is that if you had a concern of re-innervation, rebound effect, loss of efficacy, this has been shown a month ago, published on Lancet, the 3 years follow-up of this on-med therapy follow-up. And you see that it's not only preserved, the effect is incremental. The blood pressure drop at 3 years, it's in a mean of 18 to 20 millimeters of mercury systolic and 6 to 12 diastolic. So there is no rebound, the effect is there, and it's getting bigger as time passes. And the consequence of that is, as you can see, the number of medications that patients were taking, 10.3, compared to those who underwent the renal denervation at 3 years is 7.6. So a long time, these patients kept on having their drugs, because this is an important concept. Renal denervation will not free you of any drug, will help you to keep your blood pressure on target, but with less drugs. So the drug burden, the fact that you have to remember taking the pills, you forget, you don't like, you have collateral effects, and this creates what we call non-adherence of the patients, is much lower because you need less pills, and this is significant. So the always effect of the renal denervation is maintained at 3 years. And this is another very good news. Indeed, you see that patients having a blood pressure, systolic blood pressure below 140 is over 80% among those having pills plus renal denervation, and is just a little bit more than 40% in those who did not undergo the procedure. So this shows clearly the additional effect of renal denervation. And last, when we talk to real life experience, we have this important data that derived from the Global Simplicity Registry. This is a huge registry performed with radiofrequency renal denervation that has been including patients since already more than 5 or 6 years in worldwide. So you see that there are more than 3,000 patients that have been treated, with many of them having already 3 years follow-up. So in terms of efficacy and safety at long terms, this is very important data. These are not patients selected for a randomized trial. These are patients included in a registry because of resistant hypertension. And as you can see, again, the efficacy of the treatment gets more and more important a long time, from minus 13 millimeters of mercury 6 months after the therapy to 16 when you measure the blood pressure in your office, or from -7 to -9 when you do the ambulatory blood pressure. This has been demonstrated in all subgroups, patients with AFib, with diabetes, with CKD. And again, the reduction of the drugs a long time is significant in these patients. There is still a 20% of patients that, despite the drugs and despite the renal denervation, are not yet on target, and their blood pressure systolic is higher than 160. But this represents nearly 20 to 25% of patients. Last, it's an experience performed in my center. Why is that important? Not because I want to show you what we publish a paper, but just to show you that all what have been shown before has been sponsored by the company. What you see in this paper has been performed in my center with the radiofrequency device. The Medtronic has nothing to do with this data. It's our experience with very, very critical patients. These are not patients. I always say we don't treat in Verona patients who are hypertensive. We treat patients with hypertension, but have heart failure, acute MI, AFib, diabetes, COPD, peripheral arterial disease. And in this population of patients with CKD, in most of them, you see that the mean GFR was 47%, but we have patients in dialysis also in this series. The blood pressure drop is identical to that I have shown you in the studies, either in the randomized or in the registry. It's about -7 systolic after 3 months. There is an incremental effect at 6 months and even more at 12 months. And which is very important of this series that has many patients with severe GFR impairment is that there is absolutely no change in the creatinine values after 1 year. To end up, this is the final slide. Andrew have shown you that the preclinical studies have confirmed that there is a reduction on the norepinephrine release in patients treated compared to control. The randomized trials have shown that there is a significant drop of blood pressure on top of medicine, and this is persistent after 3 years. And the registry have shown that this effect is observed a long time and in different subgroups of patients. Thank you.
Thank you very much, Flavio. Are there any questions from the audience? There is one, yeah? Please go to the microphone because of the audience that is connected online.
Thank you so much for this excellent presentation. I'm Dia Hakim from Brigham and Women's Hospital in Boston. Just have a question. I think we know that for hypertension, the lower the better. But do you think that lowering blood pressure can be translated after to more clinical outcome points like mortality or left ventricular dysfunction?
Very good question.
Mm-hmm. The patients we have been treated are really severely hypertensive. And even with the therapy, the best what we can get is to put them on target, which means systolic below 140, diastolic below 90. I can tell you we had only one case out of nearly 90 with a very young lady who came with an almost non-human therapy in terms of amount of drugs and doses of drugs. And she needed to be sent to the hospital to intensive care unit because of a hypotensive crisis. But the drug therapy had not been changed, and after 3 months and a half, she really fell down because of these drugs. Now she is taking normal therapy, 1 beta blocker, 1 ACE inhibitor, 1 diuretic, and she has absolutely normal blood pressure. So I think it's important to set the therapy. This is not the first thing to do. After you treat the patient, you should wait until you see the effect, because if you take the pills immediately afterwards, you will see that the pressure goes up, and then you don't believe on the therapy. And so it's very important to follow up these patients. As far as we know, at 3 years, I am not aware about side effects related to low blood pressure.
Yep. But also, with respect to the question, Andrew, and I think the colleague is absolutely right in asking whether this should translate into improved outcomes, because this is lacking, right? We have not shown that denervation reduces the risk of myocardial infarction, stroke, hospitalization for heart failure. But we can use historical controls, right? And let's assume we'll document a 10 millimeter reduction of a systolic blood pressure. What would you expect to see in terms of relative risk reduction for heart cardiovascular outcomes?
Well, there's a meta-analysis in the Lancet by Lewington looking at mechanisms of blood pressure control that would reduce office blood pressure by 10 points. And what it showed is a reduction in MACE of 20%, a reduction in all-cause mortality of 16%, reduction in stroke of 27%, heart failure by 28% for a 10 millimeter reduction. And it appears that we get that if we do it with salt reduction, weight reduction, all the different drugs. So I guess the question is there a mechanism by which renal denervation's blood pressure lowering would escape that? And the answer seems it's unlikely. I actually think it might be the other way around, because you're getting the therapy every day, whereas in the clinical trials, they may not have been taking their pills every day, and weight fluctuates. So I think it may be more bang for the buck in terms of outcome reduction. In terms of how to do an outcomes trial, it's really difficult. If you look at a trial of a single therapy back in the 80s, you might have had a Tenolol versus placebo. The pressure in the control arm in that group was 165 systolic, and they were left at that for 5 years. And they had really high stroke and heart attack rates. That's why we treat blood pressure, because we found out in these trials that you must treat blood pressure. So what's our control arm for an outcome study for denervation? If we do it in mild hypertension, the trial will probably cost over $1 billion and will take years and years and years to recruit to. And we'll probably already have an answer by then from the real world. I think there's no reason to suspect it won't do what weight loss exercise, salt reduction, alcohol reduction, amlodipine, candesartan, and so on do. And the FDA agrees, of course, because new antihypertensive drugs don't have to have outcomes data anymore. They just have to show comparative effectiveness.
Yep.
Thank you very much for that, Andrew. Flavio, if I could bring you in again, we've got 2 questions actually from the audience again, related questions on that renal question and what we should consider in terms of renal function. So the first is, what happens to renal function in the long term after RDN? And the second follow-up question is, can we consider this in patients on hemodialysis?
Okay, very, very nice points. So if the patient has already an impaired GFR, because he has diabetes, he has chronic kidney disease, which normally is secondary to hypertension, what we have learned is that with a cautious procedure, you can do the procedure with less than 60 or 70 milliliters of contrast media. This is harmless. You hydrate your patient before the procedure, you continuous hydration, like just with any other contrast-based procedure. And in this case, you don't have contrast-induced acute nephropathy. And what our nephrologists say is that due to the better control of blood pressure, you will preserve nephrons at the long term. So there is a natural history of the chronic kidney disease based on the diabetes, the hypertension, whatever this is, that makes the renal function impair a long time. But the most important stressor for the kidney is high blood pressure. If you control blood pressure better, despite this little bit of contrast that you have given to the patient, the renal function will get better at the long term. And this is a very, very interesting point that we are studying together with our nephrologist, and it's a fascinating point. Because nephrologists know exactly which is the drop of the GFR per year in these patients. And what they see is that this drop is reduced and for years is maintained. Then in the end, of course, the disease will progress. But the better the blood pressure control, the longer the benefit on the kidneys. And the other question related to dialysis, it's dialysis, of course, It's a more difficult setting. The vessels are smaller, but what is an incredible help for these patients is to avoid hypertensive peaks that normally create pulmonary edema and acute need for hospitalization. This is the most impressive effect that we have observed in these patients. And then you have young patients in waiting list for transplantation that cannot be transplanted because of very high levels of hypertension. These patients improve their blood pressure control and can undergo kidney transplantation. This is our experience. So it is effective.
That's fantastic. And I think we've just got one follow-up question, if that's okay, just on the same point. Can we consider this in patients who have a single remaining kidney?
Yeah, we have published this example also. We had a patient with a previous nephrectomy because of a malignancy, and he developed very high blood pressure, and we treat one kidney, which was a normal kidney, and we got effect. There are two cases as far as I know. You may know better than me, but
But it's probably not the right patient population to start with, right? Neither those patients on dialysis nor those with an eGFR below 30 ml per minute, or patients with a single functioning kidneys. They have been excluded from the randomized sham-controlled studies, and you need to be well-trained, you need to have experience with the procedure to do that safely, also in patients with very low eGFR values. Would you agree?
Yeah, absolutely.
Any further questions from the chat?
Yes, so if I could bring David in now. There's a question that I think will be related really to your talk. Can you talk about the exact indications for the procedure? At which blood pressure values are you currently telling your referrers that it's time to refer for renal denervation?
Why don't we hold that thought for this presentation? But that said, of course, in the clinical trials, we've revisited our a new generation of renal denervation trials to include patients largely with combined hypertension, meaning an ambulatory blood pressure, systolic blood pressure of 140, or an office blood pressure exceeding 150. We've included in the Spiral program combined hypertensive patients with a diastolic that exceeds 90 millimeters mercury. And yet there is ample evidence, too, to support isolated systolic hypertension benefits with renal denervation as well. And this is part of a newer trial that we're embarking on called AFFIRM, which will be 1,000 patients with much less restrictions than the more rigorous criteria of the randomized clinical trials, in which we're inclusive of patients with elevated isolated systolic hypertension, but also combined hypertension.
All right. So why don't we use that question as an introduction to your talk? Connecting with referring physicians, multidisciplinary approach to patient selection. David Kandzari.
All right, terrific. Welcome to the opportunity to be with all of you in person and to be part of this symposium related to renal denervation therapy. To be sure, renal denervation has traveled a very storied path from unbridled excitement to the Simplicity Hypertension 3 study and a phase of disillusionment, and now the succession of progressive clinical trials experience that demonstrates not only the safety of renal denervation therapy, but its efficacy. Its efficacy now established in 5 consecutive sham-controlled, blinded, randomized clinical trials, and with 2 different modalities of energy delivery, radiofrequency and intravascular ultrasound. So in parallel with the evolution of evidence bases supporting renal denervation therapy, and largely driven by the experience with radiofrequency energy delivery from the Simplicity program as being the largest and the broadest and the most the longest in duration of renal denervation programs, there's been this succession, this progressive annualized increase in proposed documents from societies and consensus documents inclusive of renal denervation or considering renal denervation in some way with regard to development of hypertension pathways and referral programs, patient and clinician education, and most importantly, perhaps, thinking about this therapy as a complement to existing pharmacotherapies and lifestyle interventions. And to focus on 2 examples of such, the recently published European Society of Hypertension document focuses not only on the evidence basis of safety and efficacy, but representing renal denervation less commonly as an alternative therapy to pharmacotherapies or lifestyle interventions, but more commonly as a complement or an additive therapy for patients with uncontrolled hypertension. And an important emphasis or focus of this document is a common term that we'll address quite commonly through this presentation with regard to shared decision-making, that is, informed decision-making on behalf of the patient and representing the patient's preference as well. And very similarly, in the more recent, more contemporary societal document from SCAI, the Society of Coronary Angiography and Interventions, and the National Kidney Foundation, in this consensus document, really there's highlighted the opportunity for device-based therapies for hypertension predicated in the context of a large uncontrolled patient population with hypertension, our leading cause of death and disability worldwide. And not only focusing on the evidence basis, but thinking ahead of how in a multidisciplinary fashion we may create hypertension care pathways and programs based on the level of evidence and informing patients and helping inform their patient preference as well. So with that background, maybe perhaps it's time that we refocus our considerations of hypertension more carefully on how we think about other chronic disease state conditions. One of them, for example, being diabetes, which in the current year exceeds over 530 million individuals globally and translates to nearly $1 billion of healthcare costs. So substantial global public health impact. And when we think about the management of diabetes historically, we were reliant on a single point of care measurement, the blood glucose test, which disappointingly still in many geographies exists today. But over time, a simple blood test, the hemoglobin A1C, in the early 1990s then became part of the therapeutic armamentarium, or at least informing therapies with regard to assessing the burden of glycemic control. And that now has become a standard of care in most clinical practices. But to date now, we have newer technologies that provide continuous monitoring of blood glucose, but at the same time, in real time, provide feedback and treatment at the same time. So real-time treatment can be implemented. And in many ways, we should think about this for the leading cause of death and disability, hypertension, which has very poor control, with the majority of patients not meeting societal or guideline-recommended treatment goals of blood pressure. Just to expand on this concept a bit more, if we think about utilizing the glucose analogy, if we think about point-of-care testing with blood glucose, these simple point-of-care tests may not represent not only the time and target range that an individual is for blood glucose, but it may grossly over or underestimate safety concerns of profound hyper or hypoglycemia as well. And as an example, if we really look at a continuous algorithm of blood glucose control instead, then we really track the potential inefficacy of a current therapy with regard to this chronic disease state condition that has so many end organ consequences. And so in the case of hypertension too, we're still very much reliant on that point of care test. That is the simple office blood pressure measurement. And home blood pressure measurements are an advancement, and we have ambulatory blood pressure measurements as well, but these are not favored by patients. They're largely impractical in many instances, and they're not widely used globally in hypertension practices. But we're moving into an area still as of yet unvalidated of continuous blood pressure measurement technologies. And perhaps short of that, it's probably time for us, at least short of those advanced technologies for blood pressure, to at least start to think about an individual's burden of hypertension rather than just visit-to-visit measurements of office measurement blood pressure assessments. And one of this is time and target range. And Felix has presented just a few moments ago data from the Global Simplicity Registry, and we've also presented just in the previous session from the Spiral OnMeds sham-controlled randomized clinical trial that through 3 years of follow-up, renal denervation therapy affords patients a significantly greater time in treatment range, time in targeted range of blood pressure compared to those individuals treated with or randomized to the sham control cohort. And this falls against the background of a similar number of medications, and if but anything, a higher medication burden in the sham control group that if but anything would bias against the benefits of renal denervation therapy. So when we think about the potential benefits and reasons why we are all collectively here today is to begin in the development of a hypertension pathway program to think about physician and provider education and in a multidisciplinary approach from advanced practice providers at nurse practitioners, physicians assistants, internists, nephrologists, dedicated hypertensionists, cardiovascular physicians, and other endocrinologists and other practitioners. But then to move beyond that for champions of hypertension care, many of whom are here today, to then develop a dedicated program that can be integrated into societies and be recognized as such, that may be accredited by the European Society of Hypertension, or alternatively in the United States, the American Heart Association. But then for those programs to coalesce with the hospital programs to raise public awareness, whether it's through social media or other public exposure events, to raise awareness of a disease state that is largely asymptomatic until end organ failure ensues and it was irreversible. So as part of this issue of extending the awareness of the impact of hypertension to individual patients, in part in deciding the availability of treatment opportunities for patients is to envelope into the decision-making for renal denervation therapy, should it become commercially available, patient preference and shared decision-making processes, which are so well emphasized in both the European and the American documents. And specifically, while a healthcare provider's endorsement, while a physician's recommendation of a particular therapy, whether it's a device or a drug therapy, may be the important, most influential factor in a patient's decision to receive or accept that therapy, patient's preference alone may be colored by many integrated experiences, whether it's adverse effects with blood pressure medications, whether it's simply being educated about the clinical impact and sequelae of uncontrolled hypertension, or maybe having firsthand adverse experiences or an adverse event such as heart failure, renal failure, or perhaps a prior stroke with poorly controlled hypertension. All of this being enveloped into the shared decision-making process. But what is challenging about thinking about a device-based therapy such as renal denervation for hypertension is that there is a disconnect. There is a disparity between patient preference and physician or clinician endorsement for a therapy like renal denervation. And as an example, clinicians, whether proceduralists or non-invasive cardiologists or clinicians, are more likely to promote, to advocate a therapy like renal denervation therapy more exclusively for patients whose blood pressure levels are very severe and or whose medication burden is very high, for example, 4 or 5 or an even greater number of medications. But this is indeed the complete opposite of a patient's preference, because patients, when surveyed, are relatively even with regard to their preference for renal denervation therapy, independent of the number of medications that they are taking. Indeed, if anything, the greater number of patients may prefer renal denervation therapy who are not taking medications. And further, the interest in a therapy, an alternative therapy like renal denervation therapy among patients, is independent of the number of medications they are taking as well. Altogether, roughly 1/3 of patients surveyed with hypertension would rather undergo an interventional single point of treatment intervention like renal denervation therapy, provided that rather than, if their blood pressure is uncontrolled, rather than escalate their medication burden. But perhaps the most sophisticated, the most rigorous method of surveying patient preference, rather than a simple survey or poll of would you rather undergo renal denervation therapy, which is still very meaningful, is to perform a discrete choice experiment and to survey patient preference through a methodology that equates what is the maximally acceptable benefit with what is the maximally acceptable risk of a particular drug or device therapy relative to the minimally acceptable benefit that I'm willing to receive. In other words, what is the maximal risk that I am willing to undertake for what minimally acceptable benefit? And we performed this in 400 individuals with uncontrolled hypertension in the United States, a patient population who was representative of the uncontrolled patient population in the United States and abroad, and representative of the patients who are enrolled in the Spiral HTN clinical trials. As an example, the average blood pressure for this patient population of 400 individuals surveyed was 155 over 95 millimeters mercury, and more than half of the patients were on 2 or more medications in an attempt to achieve blood pressure control, yet unsuccessfully. And in this analysis, among these 400 patients, each individual addressed 12 of 96 questionnaires posed to them, very representative of this figure, in which there are 2 potential treatments, 2 hypotheticals, treatment A and treatment B. Treatment A may be an intervention, treatment B may be a drug. Both different therapies to achieve similar degrees of blood pressure control have attribute levels, that is, the number of medications that may be required to achieve an improvement in blood pressure control. They may be different degrees of improvement in blood pressure control and different durations of blood pressure control as well. And drugs and devices have adverse risks, adverse side effects. And we graphically represent that to the individual to increase comprehension with regard to drug side effects, with regard to vascular complications, with regard to late-term consequences such as renal artery stenosis, which with renal denervation therapy, to be fair, is almost case reportable. It's so uncommon. But whether it's a device or a drug therapy, the greatest driver of patient preference is efficacy, to achieve a reduction in blood pressure. And expectedly, a therapy is even more preferred the greater the magnitude of blood pressure reduction that can be achieved. But even modest reductions of blood pressure, up to 5 millimeters mercury, are a more important driver or a more important preference than other factors represented in this figure. Second most important to individuals in selecting their therapy is durability of the therapy as well. Now, indeed, patients may not prefer to undergo an interventional procedure if it can be avoided, but as I'll share with you in a moment, this is far outweighed by the preference or the potential to achieve efficacy in blood pressure lowering and to have a durable result. And as an example of such, in modeling from this analysis, 77% of the individuals surveyed would prefer a therapy like renal denervation if it could provide at least a 10 millimeter reduction in systolic blood pressure, which is in fact what we have observed in the clinical trials, if the duration of effect would be at least 1 year, and indeed we've shown this out to now 3 years through GSR and the Spiral HTN OnMeds program, and even at the tolerable risk of temporary vascular complications or potential stenosis of the renal artery of up to 20%, which is of course unheard of, but in a sensitivity analysis, they're willing, in short, patients are willing to tolerate very high risk levels to achieve efficacy and durability of their care. So I'll summarize perhaps, and to address the question raised by the group and the audience with regard to who might be the appropriate candidates for renal denervation therapy, rather than focus on specific numbers per se of blood pressure, I'll share with you the consensus from the SCAI National Kidney Foundation that we endorsed, and that is that appropriate candidates, should this therapy become commercially available for renal denervation, would be those individuals with persistent uncontrolled hypertension despite guideline-directed medical therapy and encouragement of lifestyle interventions. Importantly, hypertension needs to be confirmed by alternative means than just a simply office blood pressure measurement alone, the single point of care method, and ideally with ambulatory blood pressure assessment or at least serial home blood pressure assessment as well. Importantly, secondary causes of hypertension need to be excluded, and perhaps treatment priority would be afforded to those individuals with uncontrolled hypertension who have elevated cardiovascular risk. For example, individuals with a prior cardiovascular event or evidence of end organ damage. And importantly, this needs to be a shared decision-making process with informed patient consent, ideally inclusion of family members, and very importantly, level-setting expectations. When I perform renal denervation, I don't tell the patients that their blood pressure is suddenly going to be 120 over 80 by the next day. It's informing the time course and the degree of improvement that also needs to be translated to patients. Preferably, the endorsement for a therapy like renal denervation for a patient with uncontrolled hypertension would also involve at least one additional healthcare provider who has a background experience in the care of patients with hypertension, such as a cardiologist, a nephrologist, an internist, or other. And finally, of course, it needs to be performed by an experienced operator who has skill sets. There is a learning curve to these procedures and has the right equipment. There's a learning curve, but it's certainly translational to the broader interventional community. Thank you.
David. So in the interest of time, I think we will show our the answers to the polls that we've done already in the background, just as I sum up. So we have really had a very interesting conversation today. We've really taken the field from the beginning of renal denervation, the origins of the techniques and the mechanisms of action, all the way to what to do next. We've learned that our understanding of renal nerve anatomy has really changed from Andrew's talk. We've learned that even our ability to treat with various techniques has really changed from the kind of more rudimentary radiofrequency ablation to now the ability to really deliver radiofrequency energy to targeted areas and much more precisely than we had before. From Flavio's talk, we obviously learned a lot about the efficacy of renal denervation, and we've learned that from the off-med trials, we were shown the evidence of efficacy. From the on-med trials, the ability to really see efficacy in a real-world population or a more clinically representative population. And finally, from the registry data, the ability to see durability of the technique and blood pressure control over time. And then finally, from David's talk, we really started to learn about patient referral pathways, how we can develop these in our clinical practice, and importantly, that there are lots of consensus documents out there that help you to work out which patients you need to target this for, and how you can come to shared decision-making ideals where you talk to the patient about what they might have in terms of patient preference and pill burden, and trying to select the right patients for this technique. So finally, I think I'd like to thank the panel. Thank you very much, Felix, for chairing the session today, and to our speakers, Andrew, Flavio, and David, for some fantastic presentations. And thank you to the audience at home and here in the studio for being really interactive and giving us lots of fantastic questions. Thanks very much.
Thank you.